So, welcome to the first Multidisciplinary Critical Care Journal Club. We're talking today about non-invasive ventilation for pre-oxygenation. This actually came about because one of our RTs who's here with us today asked why we were using NIV to pre-oxygenate someone about a week ago, and that was right after this trial had come out. And we talked about it, and he asked me to send it out, which I think is really great to pass on the evidence. And we sent it out to the charge group of RTs, and immediately a flurry of emails came back with all the reasons that this may or may not apply to our patients. And so what Murad and I think is really important is have those conversations openly, because we're going to apply this evidence, we're going to discuss it amongst ourselves with critical care physicians. They're going to get discussed amongst the RT group. And like the vast majority of things in critical care that we decide and then other people help us actuate, we can't do it without you guys. So as opposed to discussing this amongst just our group, this is where we get everyone to give input. So critical care intubation is hard, not as hard as this person is making it seem, but it's hard. Patients have patients have unique physical and anatomical physiology and anatomic characteristics that make it challenging. Two papers that I think are useful to talk about. The first was a really large prospective study that looked at 3,000 critically ill patients and their intubation. They found that the rate of adverse events are quite high, almost 50%. Pretty significant rates of significant hypotension, significant hypoxia, and 3% of patients have a cardiac arrest, which is more than we would like. And that's important because not only did that lead to mortality both upfront, but actually if you follow the patients who are hypoxic, they didn't necessarily have worse mortality immediately, but if you track those patients over time, they did do worse. The other papers you say, okay, that's taken from 200 places in 25 countries, but what's we're a high-performing center, do we have good outcomes? Well, probably the best evidence is the device trial, which was just recently published 6 months ago, showing that for almost everyone who is an anesthesiologist that trained 20 years ago, video laryngoscopy is better for intubating critically ill patients. And so this is 1,400 patients across 15 expert centers in the U.S. And even in that group where they're in a trial, they're at expert centers, they have awesome critical care and emerge research groups, there's still a fairly significant rate of hypotension, but a significant rate of hypoxia, and 1 in 200 patients have a cardiac arrest during intubation as critically ill patients. And this isn't just patients who are severely hypoxic or severely, this is any critical care intubation. If you look at the guidelines from the British Journal of Anesthesia, from SCCM, from UpToDate, there's a lot of recommendations, not really based on high quality evidence. So it's recommended that you use a semi-Fowler position. It's recommended that you can use high flow nasal cannula, that you can use NIV maybe, that you should give medications if you need to, and that paralytics are generally favorable. But the only real recommendation that's strong is the use of paralytics. And so this group, the Pragmatic Research Trials group out of the US, wanted to study this more in detail, and there were some small studies that focus on this question and say, is NIV the optimal way of pre-oxygenating patients to try and prevent hypoxia and other complications? So when we evaluate these trials, we use a framework called PICO, which is not the Mexican salsa sort of alternative, but stands for Population, Intervention, Comparison, and Outcome, and we'll go through those. So the population is actually quite broad. They describe this as any critically ill adult undergoing intubation. This is important. It came out of the Pragmatic Research Group, and so pragmatic trials, and John or Murad or anyone else is welcome to jump in, but pragmatic trials are designed with the idea that we used to design clinical trials with an incredibly focused question to give us an incredibly focused answer, but then it couldn't be applied broadly. And so when authors decide to do a pragmatic trial, the idea is that you're going to take a broad group of patients, apply one intervention, and largely leave everything else up to usual care, so that you're not left with a very specific recommendation. We can generally say that this is helpful, and that's what they did here. So they didn't look at any specific subpopulation. It was just any patient who was thought to be critically ill in the emergency department or the ICU getting intubated. They had the usual exclusions, and most of these are because it's an American study. So American REBs don't allow you to research on people who are pregnant or prisoners. Anyone who was already on positive pressure ventilation for another reason, like they were on NIV and were failing it. Any patients who were apneic to begin, any patient where they weren't able to set up the machine to do this sort of thing because they needed to be intubated right now. or if the operator just deems that either of the two approaches was required, although we'll see that later on. That was fairly rare. The intervention, so again, very broad statements. NIV provided either via a conventional ventilator or a dedicated NIV machine, and those would be like RT5s or RV60s, was the intervention. Helmet was not included, but this is a great picture of our fearless leader. They gave, again, pragmatic trials for the settings at the discretion of the provider, but generally they recommended 100% FiO2, something along the lines of 10/5 and a backup respite rate of 10. And then apneic oxygenation with either high flow nasal cannula or just a flush rate nasal prongs underneath the CPAP or during the intubation procedure was at the discretion of the provider. The comparison group, which is sort of standard of care, was 100% FiO2 by a non-rebreather or a BVM, but in that scenario, they were instructed not to give actual breaths, just use the BVM as CPAP with maximum flow rates. There's no comment in it about whether or not they were using a PEEP valve or not. And then again, apneic oxygenation was very much left to the provider's discretion. There's a bit of a schematic showing in the NIV group, they're mandated to get non-invasive ventilation, and that's recommended that's continued during the period where medications are administered, RSI. And then you can BVM them if you want. Most of the patients just got ongoing NIV. In the oxygen mask group, they received their therapy, and then were recommended to continue that while the rocuronium or whatever other induction agents they gave take effect. And again, you can choose to then give them vague mask ventilation. All the instructions were no. This is all left up to the provider. The outcomes. So the primary outcome was hypoxia during intubation, and they defined this hypoxia as any saturation less than 85% at any point between when the medications were given and then 5 minutes after the patient was successfully intubated. I think is reasonable. We'll talk about that as an outcome because I think it's important afterwards. They had some defined secondary outcomes. So the lowest oxygen saturation at any point during that same intubation period. And then they had some exploratory outcomes that were predefined, but they knew they weren't powered to detect this. And so any significant hypotension, new or increased vasopressor use, or any cardiac arrest during intubation. And then safety outcomes, because I think one of the things that came up in our email discussion was, is this going to cause other effects that we're not thinking about? So they looked specifically at aspiration, and aspiration during intubation was defined by the provider who did the intubation, which is sort of tricky, and there's not a great way to adjudicate that anyway, but we'll talk about that in a second. Any new chest X-ray infiltrate within 24 hours as a marker of an aspiration pneumonia or pneumonitis. And they looked at their oxygen saturation and their FiO2 24 hours after intubation, again, trying to assess for is there a signal towards some clinical or subclinical aspiration during that intubation process. For the statistics statisticians in the room, this was an investor-initiated is what that should read trial. It was funded by the U.S. Department of Defense, but in a very sort of blank check format. There wasn't any, this wasn't run by a ventilator company or an NIV company. They published and had a pre-specified statistical plan, which is good. All these patients were included in the trial under a waiver of consent, but they were subsequently informed, and they had an appropriate randomization strategy. They had trained observers in the room that looked at the oxygen saturation, the number of attempts, whether the lowest blood pressure and vasopressors. But the operator themselves was reporting on the view, whether there was aspiration. The operator reported on cardiac arrest, which is a bit weird because I would think the person in the room probably knew if they had a cardiac arrest as well. And the number of previous intubations by that provider. And then trial personnel after the fact extracted clinical outcomes and baseline characteristics. Importantly, no one was blinded. It's pretty hard to blind someone if you're on NIV or 100% face mask. They likely could have blinded the trial personnel adjudicating outcomes, some of the outcomes afterwards at least. But hard to run this as a trial totally blinded. They had an appropriate power calculation and intention to treat analysis. So all quite reasonable. So looking at the patients, important to note, this trial included about 1,400 patients, but they assessed 4,600 during the time period for eligibility. There were some who didn't meet the inclusion criteria for a whole variety of reasons, but they could have included a lot more patients than they actually did, and I think that's important to talk about. Because if you look at the patients who were excluded, this is something patients we should hesitate in applying this evidence to. So a lot of them were because they needed to be intubated right away, and in an emergency department or ICU, that makes sense. And I don't think we would, so clearly we shouldn't be delaying intubation and if someone needs it to set up NIV. That doesn't make any sense. If you're already on positive pressure ventilation, these authors, everyone who's doing this thinks that this probably works, and so they're not taking them off to put them on non-rebreather. They about 400, so a little over 10% had some form of vomiting, hematemesis, hemoptysis, or epistaxis. So if a patient has an obvious ongoing contraindication, they say not to do it, and that's pretty clear in the protocol that they published that it needs to be at the time. So it's not, well, they vomited 6 hours ago, and they think they were reasonable with this, but it's that if a patient is actively having those problems. And then actually a relatively low number had severe agitation precluding that. But something to also note, if someone's already ripping off their face mask, they're not likely to comply with this. The remainder were all fairly reasonable. And they actually had very few that just providers said, oh, they're high risk. So that's something they tried to exclude. They tried to say they shouldn't be excluded because they're at high risk. They need to have an obvious, like something ongoing that makes them aspirate, as opposed to just, oh, I think they might aspirate. They tried to say that let's include those people in this study. And then if we look, they were about 1,300 underwent randomization. They actually, for a trial that's, is a treatment, an intervention that is hard to actuate, they actually had quite good results where the vast majority of the patients in the non-invasive ventilation group got non-invasive pre-oxygenation. There were 22 who didn't, and I think that's reasonable for this kind of study. And as you would expect, more patients, it's easier to put on a non-rebreather than it is NIV, and so there were very few patients who crossed over from a non-rebreather into NIV, but they were analyzed in the intention to treat, which makes sense for this. These are the baseline characteristics. They look like our patients. They're around 60, a little less than half are female. About 3/4 happened in the ICU versus 25% in the emergency department. They have a reasonable number of comorbidities, lots of shock, lots of pneumonia, lots of altered mental status, and reasonably sick people. And interestingly, not a lot of them were receiving high flow nasal cannula before the start, but a reasonable number were, and I think these were mostly sort of sudden desaturations. If you look at the intubation procedure, looks a lot like the way we intubate people in London. So again, these are patients who don't need to be intubated immediately, so most of them are being pre-oxygenated for more than 3 minutes. The lowest oxygen saturation, if you look at this, so this is even prior to intubation, there's immediately a separation in the groups where more patients who are receiving NIV to pre-oxygenate are actually getting above 95% prior to intubation. It's not a huge point estimate difference, 5 or 6%, but there's a statistical significance there. And then actually at the time of induction, that's also the case, where more patients at the completion of pre-oxygenation are achieving greater than 95% oxygen saturation prior to starting. And then again, similar to how we intubate people in London, the vast majority of people almost everyone is getting some form of sedative, as we would hope, and 99% of patients are getting some neuromuscular blocking agent, as we would do commonly in our practice. It's an American study. If you look at the supplementary data, lots of etomidate, less ketamine, but similar to how we do that. Sorry, I'll just go back for 1 second. In terms of apneic oxygenation, so the vast majority are getting supplemental oxygenation. That's in the NIV group was almost always NIV, which makes sense. If they're already on NIV, why not continue that? In the oxygen mask group, it's usually just nasal prongs underneath. And then looking at the outcomes. So the primary outcome was hypoxemia, less than 85% oxygen saturation, and there was a fairly significant statistical difference in that 9% of patients in the NIV group had hypoxia during intubation, and 18% of patients had it in the standard therapy group. And so that's a p-value of 0.01 if you like p-values, but the estimate there is that there's a 9% difference, which means if you treat 11 people with this therapy, you prevent hypoxia in 1 person, which is better than most of the things we do in the ICU. Most of our steroid trials you have to treat 50 patients to maybe show a benefit. Looking at their exploratory values, you would expect then that generally the patients still do reasonably well, but there is a lower median oxygen saturation in the oxygen group, like you'd expect. Interestingly, there was a signal towards potentially less cardiovascular collapse or less less hypotension in the NIV group, which isn't really what we would expect. We always talk about the hemodynamic consequences of NIV, but I can't really say what that's to. Potentially it's because they're less hypoxic, so they're doing better overall in preventing that physiologic collapse, but it's not causing people to become hypotensive. And really interestingly, and the authors would say they're not powered to detect a change in this, but 7 people died in the oxygen mask group, and only 1 person died in the NIV group, which, if it's true, is a point estimate of a 1% reduction in mortality, and was actually significant. The authors would clearly say that doesn't prove that this saves lives during intubation. It's not powered to make that determination, but there may be a signal there that's worth sort of exploring and makes sense. There are safety outcomes, so there were no differences in the rates of aspiration, there were no difference in the rate of chest imaging, there was no difference in the rate of pneumothorax, there was no difference in the median oxygen saturation at 24 hours, and there was no difference in the median FiO2 at 24 hours. So essentially all the things that we looked at to both see aspiration or see consequences of aspiration were the same. So that's kind of the trial's data. I'm happy to open questions either from here or from UH, but I know I took kind of the conversation we had via email with the charge RTs about some of the questions that were brought up by this study and pulled out some of the supplementary figures. So if anyone wants to pipe in, fire ahead, and if not, we'll go ahead.
Michelle?
Yeah.
I guess my question is, I would say for a lot of our patients, if not the vast majority, we pre-oxygenate them on high flow.
Mm-hmm.
That wasn't studied, it was listed as one of the limitations.
Yeah.
So to create a big practice change, which isn't comparing apples to apples with what we do here in London, I would like to see a study that compared non-invasive ventilation to high flow oxygen therapy for pre-oxygenation.
Yeah.
Eric, can you repeat the question, please?
For sure.
It was a comment more than a question.
It was a comment from Michelle that our standard therapy is pre-oxygenation and apneic oxygenation with high flow nasal cannula, and that because our standard therapy wasn't what they would use in this trial, there were some patients on high flow, I think 30% if I look at the supplementary data, but not all by any means, that we wouldn't change our practice because we're not, because this wasn't comparing what we do to a different strategy, it was comparing 2 strategies that we don't do. And I think that's really reasonable. Took me a while to find the percentage of patients in the study that in the standard therapy group that had high flow, and it was low. It was like 30%.
No, those people were supposed to switch to NRB then?
Pardon me. They could still have it on. They had to have an NRB over top.
Oh.
So if you're on high flow to start, you could go non-rebreather on top,
Mm-hmm.
and then apneic with high flow nasal cannula.
Oh.
The data doesn't have an answer to that question. There's a podcast where these authors came out on it, and their stance would be, so I'm just going to straight up say what that is, which is they think that it's the positive pressure that makes a difference. It's the prevention of it's the re-recruitment, the prevention, and the treatment of atelectasis that makes a difference. And high flow provides some CPAP. We know that that's true, but it's not providing anywhere near the scale of NIV. And so they didn't feel like they needed to perform that study because that wasn't what they were assessing. They were assessing the effect on positive pressure, which is not provided with high flow. There is one small European study that answered this question that had 100 patients in each arm. The point estimate favored NIV, but it was a vastly underpowered study, so it was a non-significant difference. But it's hard to take much from that with 120 patients in each arm. I don't have a true answer to that. I'm a reasonable believer in this study. I think that, and the biologic rationale is that our patients are different than OR patients. In the OR, we talk about pre-oxygenation, denitrogenation, giving them a reserve. And our patients, that doesn't work because their lungs are diseased. They have physiologic exhaustion. So I believe that the re-recruitment, the prevention of atelectasis has value.
I don't know if you want to comment on this, but when I looked at the forest plot, and it was the groups that seemed to benefit most from the NIV, it was the people that I would have kind of expected the higher BMI. So
why don't we go to that?
If it's, what did it say? The body mass index over 30, and then if they were already on really high FiO2. So I could see, you know, doing this for patients that already are at higher risk of having these adverse events, hypoglycemic events, you know, collapse and that. I don't know how we determine those, but it looked like this NIV strategy was more favorable for some of the subsets, but I just think some of the patients, and I mean, anybody's welcome to type in, but I don't know if we'd see the same benefit across all populations, or if it would be more reasonable,
The question for UH is really just the acknowledgement that, like, who are the responders, because it's obviously not for everybody. And so is it high BMI, those who start from adverse oxygenation sort of perspective? Eric, do you have an answer to this question?
So the authors put that in their supplemental information. They did subgroup analysis. So basically the idea is, do we have to use this for everyone, or can we just use it for people who are high risk? And so they looked at the effects. They separated things out by a variety of factors. The first was body mass index, and they found that, you know, at a BMI of 15, of which they had like 3 patients in the study, there was no difference. But at a BMI of 22, which is less than mine, they separated out, and there was a benefit to NIV. They looked at patients based on their highest FiO2, and they found that essentially any FiO2, the patient did better with NIV. They looked at how sick they were, so looked at their Apache score, and again, there's some crossover the reason for that is that there's just less patients with every different Apache score, but there's no signal here that a less sick patient doesn't benefit from NIV. And so the forest plot that you mentioned, they did show that there wasn't a statistical benefit in that line crosses 0 for patients in the emergency department, but the point estimate, which is what probably matters more if you're looking at an underpowered study, shows that essentially any patient group, including those who were on no oxygen in the previous 1 hour, their FiO2 was 21%, benefits from NIV. And so I would say that every patient should get this. I also would say that I say this a lot in the midst of when I teach SIM and when I talk about sort of crisis resource management skills. Don't try and be a smart doctor, be a good doctor. What's easier? That we pre-oxygenate people as part of our pre-oxygenation strategy includes NIV if the patient is eligible, or we say, okay, are they big enough? Are they sick enough? Are they on enough FiO2? Like, that's harder than I want to make it when I'm teaching junior learners, or just thinking about it myself in a hard situation about whether I should use this. I don't know if that answers your question.
Yeah, totally.
Yeah.
So cost difference between consumables for NIV versus high flow, roughly?
The non-vented masks that we use are about $25. Nasal cannula are about 50 cents.
A high flow nasal cannula or 50 cents?
Sorry, no, just regular.
Okay, what about high flow nasal cannula? What do you think?
Because they already come on it.
What do you mean?
They typically are coming from the floor already on high flow.
Supposing they aren't, I guess,
They aren't?
you know, is it much different than $25 for the mask?
No, the cannulas themselves, I think they're about 14.
Okay.
The circuit, if we're using the standalone high flow, is about 50, and a ventilator circuit is about 50, but we're going to use that anyway because we're going to intubate them. This is another concern, and Tim and I have talked at length about this with my cohort at UH. The G5s are not great for non-invasive ventilation, only because they don't have a turbine. So they don't have the same flow generating capacity that a V60 does. A V60 can create 240 liters per minute. The G5 can create 120. So if we don't have enough, and actually all the V60s are currently recalled, and Philips is getting out of the ventilator
They sure
market.
are.
They're not making anything anymore, so that's a whole other can of worms.
So the observation, just for those on the line, is that, the Hamiltons are not as good, is the new weak NIV as opposed to the good old fashioned muscle car version of NIV, which is offered by the V60s, which are effectively being phased out for multiple reasons. So what was do we have the equipment specs in the study offhand? I guess there'd be dozens of centers.
Yeah, it's dozens of centers with different models. But they did state how many, and they didn't separate out these two, which would be an interesting thing to ask the authors if we were able to, but we can see this 2 days ago. But of the patients who got NIV, 60% of them were on some form of dedicated NIV, and 40% of them were on a ventilator, or 30% of them were on ventilator NIV. So more patients on ventilator NIV, more patients on their version of a V60. I'd be interested in see them separate out and see if that made a difference.
And the cost would be different too, because it's a different single limb circuit for a V60 versus a double limb circuit for a ventilator.
So Eric, if we take away the death rate, which you've agreed is spurious and cannot be, we have to unknow that in some way, but it's hard. Are you really motivated for such a practice change on the basis of the primary outcome? Is that sufficient to, stats less than 95 gets you like really excited about this?
So this is one of the things.
So Eric, guys, can I? There's some questions at UH, and I think Amy Pope's had her hand up.
Okay, my apologies. I can't see this. I can't see the teams easily based on how my computer's set up. Can you ask the question next? Yeah, Murad, as I posed mine first.
Yeah. So maybe Amy goes first.
Hi, I'm in the RT department here at UH. A bunch of us are here watching. We had a kind of a question with regards to study. Like it says NIV. Was it specific to BiPAP or just CPAP? Our kind of question was like, is there a difference? Because there's definitely a cost differential. Like EMS uses those CPAP machines which run off of flow meters are fairly cheap opposed to bringing in a V60. Do you have any information about that?
I don't remember from the supplementary data how many actually gave it, but throughout the entire paper, they were all on BiPAP. And I guess it's a pragmatic trial. They can do what they like. The firm recommendation was for BiPAP, at least settings of 10/5. I hope that answers
Eric, just one more question here at UH.
Yeah.
I couldn't hear the difference between the consumable cost that someone answered. So is it more expensive to have NIV versus high flow? And that my second question was with respect to using the Stellar NIV ventilators, the Stellar versus a G5, which provides more flow and pressure. And my third question was about the environmental impact of waste. What do you lose more waste by disposable mass from NIV or high flow, or is it the same? So cost, waste, and effectiveness of a Stellar versus the G5.
So the question regarding cost, we acknowledge that we don't know because of the way things are kind of packaged. But
a Stellar would be a cheaper circuit than a V60.
Yeah.
The V60 is a cheaper circuit than
a Stellar is more expensive. It's cheaper than a V60.
But you can't get the same FiO2 range.
So a Stellar, unfortunately, can only do, I think, 10 or 15 liters teed in. You can't mandate 100% FiO2 the way you can on a ventilator or a V60, which would be the problem. The disposables, I think, are the same relatively between all the setups. If a patient's already on high flow, then you're opening something else, but from an environmental perspective. And then the question of cost, Michelle wasn't totally sure just because the accounting is a bit funny, but none of them are prohibitively expensive to the point that they would meet any cost threshold if this actually provides a benefit we think is helpful, is kind of how I would phrase that. Does that answer those questions?
Yes. Yeah. The primary outcome question, is it relevant to patients? The secondary outcome being increased mortality or a higher rate of cardiac arrest by 1% in the control group is also concerning. So aside from costs.
Yeah. So I wanted to talk a little bit about this because I think this is important. So this is a surrogate outcome, and Paul Cameron would ask, does this matter? Because the patient doesn't care if their oxygen sat is 84 or 86. So one of the things we look at when we look at trials is ideally we would choose endpoints that are patient-centered. And there's if you look at the literature, they look at things that affect patient symptoms, affect patient function long-term, or affect their survival. And an oxygen sat of 84 doesn't affect any of those things. But you can't study death, because if it's a 1% difference, you would need a 50,000 patient trial, and it would be prohibitively expensive, and you can't do that for lots of things. And so we're forced to use these surrogate endpoints that are not a patient-centered outcome, but we think are reasonable to use, because we just don't have the power to run 50,000 patient trials again and again and again. If you look at what sort of people who write about this and clinical trialists would say are good surrogate endpoints, there has to be a couple things. So there has to be biologic plausibility that your surrogate would affect what you care about. And we care about mortality here, and I think everyone in the room would agree that hypoxia will lead to mortality if not treated, so that seems reasonable to me. There has to be evidence linking that surrogate outcome with patient-centered outcomes, and in one of those big, large studies I looked at, the rate of they had enough patients by following enough to show that hypoxia does lead to death, and that patients who are hypoxic during their intubation, their critical care intubation, are more likely to die both during the intubation and during that hospital stay. So that evidence does exist. And then there should be evidence of some sort of threshold effect to allow you to set especially on continuous outcomes, which oxygen saturation is continuous, you get 0 to 100, there should be some level that matters. And I think you could argue, is that level 80? Is it 75? Is it 90? Is it, some people might say 95. The authors chose 85, and I don't have a strong reason to say that's wrong. But you could argue that's not severe enough. The problem is the higher you set your threshold of what your outcome is, the more patients you're going to need to recruit. This was already a 1,200 patient study that took 13 different centers and presumably a lot of money from the Department of Defense, and so no trial can be perfect. Mm-hmm. I don't know if anyone here or Murat, or I don't know if John's on, have anything else to say about that, but I would accept this as a surrogate endpoint.
I would agree, and you have indirect evidence that the surrogate physiological endpoints is actually linked to a patient-centered outcome of cardiac arrest incidence, because in your secondary analysis there is a parallel, like the intervention group had fewer cardiac arrests. I guess for me, the biggest question from this trial is, should all comers really be exposed to NIV? Because what's the biologic mechanism for NIV? Usually for pre-oxygenation, it's just a washout of nitrogen from the lungs, but presumably people who need to be intubated in the ICU are those with atelectasis or some degree of aerospace disease. And NIV is superior in recruiting lung and increasing alveolar recruitment prior to intubation, thereby functionally increasing FRC. But I'll stop there.
That
prevent any intubations?
No, commitment to intubate was there.
No. Yeah. I tend to agree with that. I think that kind of preparing for this, one of the things that I was interested in is how little literature is really available on critical care intubations. We have 80 years of pig studies and human studies and everything else that when they, in the OR, where they learned all these different ways and all these things about the physiology of intubating people who came in off the street to have elective surgery. And we know actually comparatively far, far less about intubating critically ill adults. And so I think I can't say for sure that what you're describing is correct, but there's I would say a very real signal here that this provides benefit that wouldn't occur if this was just about denitrating people effectively.
I just want to ask a question about level of consciousness, because that's always been an exclusion criteria for NIV initiation, and they didn't include it as an exclusion criteria for their study. So what would your thoughts be on level of consciousness? Because
the question is about level of consciousness as an exclusion for NIV, and I would say that's exclusion from indeterminate duration of NIV on the basis of airway protection.
But for this, you'd be okay?
And that's why they had to not be apneic at initiation, but if you're breathing, but perhaps unable to protect your airway, the short-term benefits of pre-oxygenation, I think it's acceptable. Okay. Would be my take. I would disagree with I'm unconvinced by this study, for what it's worth, because the It is not a high flow comparison arm. High flow is infinitely easier to work with from a logistic point of view, to leave it in for apneic oxygenation. The logistics of mask removal and personnel and circuits in the room, I think, are non-trivial differences in the operationalization of those two strategies. And while it's attractive to for sure believe that the positive pressure is part of the secret sauce here, that remains untested against a higher delivery mechanism of high flow. So between cost differences, between logistic differences, and the primary outcome of less than 85 is of unclear benefit to me, if I were being honest. I would not change my practice. I'm a big fan of high flow. And I would want to, unfortunately, I'm sure this study was conceived before the widespread adoption of high flow for adults, being that it's such a long study time, I'm sure, with so many patients.
Yeah, the REP was in like 2012, I think.
Yeah, there you go.
So well before COVID made us use high flow for everything.
Yeah, so I think this is and again, this is not an anti-research statement by any means, but like these are complex trials, and the lag time for this question between the REPs in 2012, maybe it was conceived possibly in like 2009.
Yeah.
Like these, it takes so long to do such compelling multi-center work that sometimes the question you pose and the way you've done it isn't evergreen by the time it gets published, which I think this is an honest example of. And it's not as though it didn't advance our knowledge, but the obvious question is you have to now do the high flow study.
Yeah.
For just to be contrarian, take that from a rat.
Yeah, Rob, more research is needed, but Rob Lieber has a question.
You always win, Murat. Damn it.
That's all we've got.
Can you guys hear me okay?
Yeah.
Yeah, no, I'm in between Murat and Rob. Like I've been a high flow fan because it works well. I've been an NIV like reluctant user because I actually, being from my surgery background, the thing that bothers me the most peri-intubation is massive aspiration, and I think that blowing air down the throat to people who, especially the high risk group who are maybe bowel obstructed or post-operative, I worry about. So I think I agree. Convenience and similarity in cost would lead me to probably still stick with our local, gold standard of high flow. But this study softens my stance. I think that NIV does work as a physiologic, rationale here. And in patients who aren't high risk of complications, who I worry about hypoxemia, this study kind of makes me, I guess I'm riding the fence between you two folks, but I'm more keen, I'm more now likely to say, yeah, let's pre-operate the NIV here than I was before this trial came out. So I won't change my practice entirely, nor do I need to change all of our practices like permanently and forever. It definitely softens my stance towards NIV in a positive way. So I think it's worth going over as a group, and I'm glad that Eric brought it forward.
We have a question from Dr. Busman.
I'm sorry if I missed it, but I just don't see what's the downside of using NIV. Even if you don't believe the study, there's a possibility it might be true. And so what's the harm? What's the
Vomiting,
downside?
Karen.
I didn't hear that there was
Massive-
a big cost
massive
difference.
aspiration
I
and
didn't hear there was
vomiting.
big negative safety consequences. So if it's not cost, if it's not environmental impact, it's not safety, what's the downside?
Yeah, I think aspiration
To
risk,
using
and I
NIV.
think the delay in time it takes to go and get a hold of the machine, set it up. I think there's like, again, I would use it, but I'm just saying that's the downside, right? Is the logistics and the risk of aspiration, right?
But the aspiration was the same in both arms, so it pushed back a little bit on
As
that.
evaluated by like the people who did the intubation and felt great about it. Like that's Mikey
Yeah.
likes it outcome, right? We all know it's just from a rationale point of view, people who are I think it's good, but highest risk people I think would be, with bowel obstructions and stomachs full of air already. I'd be a little more hesitant to pop it on as a like blanket for all intubations in the ICU.
And you're right, Rob, because there were a number of patients excluded. If we look at the concert diagram, at risk for aspiration, I think. So.
Yeah, they tried to exclude people who were just at risk. Like they did say that providers could do that, but there's specific guidance against saying, oh, I think they could be at risk. They need to actively be having vomiting, hematemesis, hemoptysis. That was the instructions given to authors. It's a pragmatic trial, so it's a lot of like, do what, if you think this patient qualifies, put them in, and if you think they don't, you can't. But they did they tried to not kick people out who were theoretically at risk of aspiration. Everyone's theoretically at risk of aspiration, for whatever that's worth. Yeah, I mean, I am someone admittedly who probably used NIV a reasonable amount before this, and I am quite comfortable leaving them on a bench.
Just getting started is what you're saying.
And I like, there's different schools of thought that have used it previously, and if someone was on it, I was always incredibly happy to keep them on it during the apneic oscillation period. And then I found doing that the logistics are not that, I don't personally find that difficult. I think the control of, I think a lot of aspiration is underdosing of roxuronium during intubation, but that's a pure hot take. So I am more likely to continue to use it, and I think that I would like to see the high flow nasal cannula study, because I think if that study came out and showed the same thing, then we'd all have to start doing this for everyone. And I think that this isn't something. So this is something either the evidence here shows that you should use it or not. You shouldn't use it only when people are high risk, because the benefit was across all groups.
So something universally north of non-rebreather perhaps is the bare minimum for what is, again, I would argue, a already outdated question, because most people, if, you know, aside from the universality of its application, the note for pre-oxygenation, something fancier than NRB is definitely proven here, and that's the most, like, the Switzerland of the conclusions for something. Again, I think the absence of a high flow arm makes this a challenging study to take it exactly at face value in 2024, but exciting, more research needed, Murat.
All right.
Indeed. I like how you anticipated all our questions with all your slides.
Tried.
Yeah, very good.
Helps when you have an email chain between all the charge RTs about the study before it starts. Happy to take any more comments from UH, and if not, maybe we'll close, and thanks everyone for coming. I think this was a good discussion.
Thanks, Eric.
We have this recorded, and we'll edit it slightly and then post it on the Critical Care Western for the people who aren't working today.
Respect.
Thanks.
Excellent. That's good.
Thanks, Eric.